So again, good afternoon, everyone, and thank you for joining today's session. My name is Casey, and on behalf of the PRRP Exchange team, we are excited to have you join today's session and take part in a discussion around pre-hospital recognition programs. Before we get started with today's session, we would like to acknowledge that the EMSC Innovation Improvement Center is funded through a cooperative agreement with the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. As a cooperative agreement with a federal agency, the EIC must adhere to executive orders and related federal guidance. Currently, EIC-funded staff are unable to engage in activities or discussions on topics that are limited by executive order. We appreciate your understanding and ask all meeting attendees to refrain from discussing topics of concern as defined within these executive orders. Additionally, the contents of today's presentation are those of the authors and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. So here we have the goals for participating in the PRRP exchange. These come from you all in your responses to the exchange survey. The goals are to collaborate and to hear from others implementing recognition programs, to collect resources in support of recognition programs, and to identify and address barriers related to recognition programs. So during today's session, we ask that you do turn on your cameras to share your experiences and ask questions of one another. So with that being said, I will hand things over to Rachel and Kathleen today to help facilitate our discussion.
Thanks, Casey. So in thinking about the minimum criteria that we all determined, what was that, how many months ago? Casey and Eleni put together this great resource for you guys for consideration into inclusion into your Readiness programs, and Casey did send out a couple environmental scans looking to determine who had included the minimum criteria into that. Casey, did you want to clarify any of that right now or wait till after the session to do that?
I think we can see if any questions come up.
Okay. Does anybody have any questions about the guidance that came out? I'm going to take silence as meaning that it is a fantastic document and nobody has any questions. Thank you, Kathleen. Yes, the two minimum criteria for pediatric pre-hospital readiness are the presence of a PEC and wait, there was one more, and wait, 3.
So I think that the minimum criteria created by the collaborative was the presence of a PEC. And then the HRSA performance measures are the presence of a PEC and skills checks. And so then we had additional stretch criteria as well.
Yeah, so there's three minimum for pre-hospital, and that's PEC, adoption of a standardized weight system, and assessing pediatric specific equipment. So those are the 3 minimum. And then the stretch generally are what's included in the technical report.
Rachel, this is Kelly Little.
Hi, Kelly.
So correct me when I'm wrong, I thought disaster plans was added to that.
That's part of the HRSA performance measure criteria, but the group did not vote on that in agreement as being part of the recommended minimum consensus criteria. So there's kind of 3 levels. There's the minimum criteria that this group decided on. There's the HRSA performance measure criteria, and then the stretch goals, inclusion of many of the items that were in the technical report and policy statement.
Okay, and for clarification, since HRSA has a minimum, that means that the programs have to. I know you and I have talked individually about this, so I
Yes.
didn't get it. Okay.
Yeah, so it's the HRSA criteria is more about meeting your performance measure and what they'll be looking at for meeting the HRSA goals. This minimum consensus criteria is more about seeing what sort of consistency nationally everybody kind of agreed to where that minimum kind of level where everybody can get to. So it's almost like that HRSA level is a little pre-stretch criteria.
I can tell you, Kelly, just going through the process with HRSA, they won't tell you what you can and cannot have. They make strong recommendations. For us in our state, the HRSA criteria is just another tier. It's just an added level. And then the stretch kind of goes on to like tier 3. Does that make sense?
It doesn't, I was, I guess for lack of a better word, and Rachel jump in anywhere because she was included in this, told to add specifically disaster plans because I had an existing criteria that didn't include that, which is fine. And so I've gone ahead and done that, but as being a minimum criteria. And my understanding is only 2 other states have disaster plans.
Yeah, for kind of compliance is the right word, but for that's in consideration of the performance measures to include that
Right.
disaster plan. Because that's part of your performance measure layers, right? The performance
Right.
measures are the PEC, the equipment check, and disaster plans.
Yep, that's correct.
Yeah. So I think where HRSA is going with encouraging people to incorporate those into your pediatric recognition programs is it's kind of, it's kind of an easy win for that 4th pre-hospital performance measure, where creating the recognition programs is one, and then they've listed within them the next 3 performance measures, PEC, skills check, and disaster plans within the recognition programs. So our minimum consensus criteria is that theoretical baseline for a kind of a national, maybe everybody can get onto the same page nationally. So more consistent national programs. And then the HRSA criteria is your performance measures, and the stretch criteria is all of the bells and whistles that we recognize not every state would ever be able to accomplish, but for those who can, it's encouraged to try and incorporate the remaining items.
So I uploaded the document into the chat so that people have a bit of a refresher. It came out in as an email a while ago, and it has the columns where it's kind of delineated out what was the collaborative's work to identify a set of criteria, what were HRSA standardized criteria based on prior performance measures, and then and yeah, and thank you for pulling that up. What were the stretch criteria, and then what are the criteria in the policy statement that we have the pre-hospital readiness data on the status of after the assessment. So this, I think that initially starting is, these 3 criteria from the PRRPC consensus process that everyone here is really devoted so much of their time to doing are the presence of a PEC, the standardized weight system, which people felt was critical, and then assessed on equipment. And I saw your comment in the chat, Mark. It's a good point. The checking of equipment question has, or competency and ability to use the equipment question has always been a bit of a bear in terms of how the measure was developed. And I don't know, I'll take a moment to kind of share a little bit of deep background history on this for some who may not be familiar. in 2014, HRSA convened a panel of experts and to, help craft information about the next set of performance measures for 2017 to 2027. And the group was really pushed hard to think broadly about like what would EMS care look like in 2027. The element of the equipment that came up, and I remember Rachel, you spoke up really about this because you were in that group. I think that everybody realized that really universally, all the agencies have all the equipment. They have the equipment because they often have to go through licensure at the state or county or local level based on whatever state rule they're following. And lack of equipment is not the problem. Ability to use the equipment is the problem. And so how did we get to a place where we could kind of quantitate assessing their ability to use equipment? And the EDC came up with a rubric, of this score of, 0 to 12 based on frequency of skills checks and method of skills checks, with a goal that a certain percentage of agencies across the country would have a score of at least 6. A score of 6 means you do probably sim twice a year, or you do skills checks twice a year and 1 sim a year. That would give you a score of 6, just to kind of like operationalize that in people's mind about what that would look like. We've never really been able to gain a lot of traction on that metric. And part of the challenge there has been that, these performance measures were released, and then a couple of years later, COVID happened and things like that, and people really weren't in ways to kind of really move that forward. But what we do know is that as more and more agencies have had a PEC, those agencies with a PEC are more likely to have higher scores with regards to the skills check. There's a direct correlation between the two. So Mark, I don't know if that kind of gets to a little bit of the heart of your challenge. In the PEDS Ready assessment, there were specific questions about, do you do skills checks in airway management? Do you do skills checks in cervical spine, spinal motion restriction? Do you do skills checks in IV placement? That's a much more granular assessment that was literally just done. But this other annual assessment we've been doing has just been like, do you do skills checks, period, yes, no, and how frequently do you do them? And it didn't really do a deep dive of mandating certain kinds of skills with equipment. So I'd love to hear your thoughts on that if you wanted to speak up a little bit. But that was, just to kind of like readdress the challenge that we have with that one particular metric.
Thanks,
And I'm
Dr.
sorry for
Allardyce.
being so long-winded.
I guess I would just say that the challenge I see with that is many of our programs have faced inconsistencies from our project officers on what standards are reviewed and whether we meet those standards. And where it's kind of nebulous, it seems like it opens the potential challenge for what am I going to design my program to look like. And I may feel it's appropriate for my state, but with the certain uncertainties, the only thing we can say about the federal government right now is it's certainly uncertain, is that if people change or they may interpret that differently. And so I'm worried that I could be on a path to having a very successful program, and if the people reviewing it change or use different standards versus Maine versus another state, how do I compare and contrast the success of my program? And how do I make sure that I'm doing the evidence-based best review of that? We formed a small group through NSEMSO, and we looked at this, and we used NEMSIS, and we looked at what pediatric procedures are being done, and we looked at nationally what were the most common procedures, and then we worked on, what did we think as educators and clinicians were the, either high risk, low frequency, or medium, and the low risk, we were kind of like, all right, do I need to demonstrate how to take a pulse of a pediatric patient when we do this multiple times? But where is that line? And that became very challenging for the group to work through. So I guess I want to make sure it's consistent, that it's evidence-based, and that ultimately HRSA's going to not upend, and I know we can't necessarily predict what a project officer is going to do, but we want to make sure that it meets whatever criteria they want, and they know how to measure what we're doing.
Yeah, I think that's a really, thank you for that. And thank you for your work within the NSEMSO Pet Council and using NEMSIS data, to kind of get some baseline of where to go. And there's been some other publications by Brooke Lerner originally looking at pre-hospital care of children and, frequency of putting in IV, 6% of kids, frequency of doing spinal mobilization, like 4% of kids. And so, these events that are not common are, ways to kind of say, well, if you don't do it often, then maybe that's a skill you should be practicing, or certainly the highest risk skills like an IO placement or something like that. But I think that ultimately, with having done the assessment over the summer, the data that you will be receiving, hopefully soon, will allow you to look at your own state and what the agencies in your own state are already doing on a much more granular level. And that can then allow for some programmatic planning of where you see we should be adding this for our state because, this is never done, or whatever it is. So that's another potential way to start to, kind of frame the rationale for the way you've designed your program and what it is you do require.
Well, can we maybe then also shift this conversation just slightly back to what everybody is doing right now? I totally hear your concerns, Mark, and we can't answer to how HRSA communicates this or doesn't communicate it, but as it relates to current or programs being created, how are you all working on this specific minimum criteria item? Have you been able to include it? Have you figured out a way to assess it? And any barriers or enablers to that? Go ahead, Dwayne.
Apologize up front, I'm traveling. In order to get an idea, I took the concept of let's evaluate what they're doing. So I created a tracking log for the agencies to use and track the activities of education and assessment of skill throughout the time they are going to be recognized, and have them submit that so that we can look at it. And during our review, whether it be the initial recognition or the triannual review, discuss with them to hear from them their challenges, their needs, and for them to hear feedback from us on where the priorities might be and how they might be able to incorporate it. So it's not an absolute immediate fix, but it's incorporated into the program over, and I had to say it this way, but over years in order to adjust and support improvement in the process.
So are you using something similar to the HRSA matrix for asking them how they're doing it, or what are your questions to the agencies?
So I just asked them to track, so what activity did they have? When was it? What was it about? Who was there? That way it can track the individuals so they know who attended, but we can take a look at it. So now I'm not going to specific about frequency, but more just giving them a general tracking method that then we can interpret how often it's happening. but more importantly, we can interpret what's occurring and then having that one-to-one conversation with them, why it's occurring, why they chose that particular subject or that particular piece of equipment, and why they might want to choose something through doing some data drilling on, the times they touched a piece of equipment, they did a particular procedure involving peds, and hopefully give them that information during the course of the next couple of years in some of our PEC learning sessions, so that they can incorporate it into their activities in the future. But I don't expect any standard to be out there. It's coming from a medical director. It's coming from a service educator. It's coming from what we think we need versus what we know we need. Things like that.
Gotcha. Cool. Thank you. Eric.
Yeah, hi. So New Jersey took the performance measures for the state partnership grant, and we took the pediatric readiness standards and our regulation and kind of incorporated it into our program for recognition of our BLS program, our BLS agencies and our ALS agencies. And our initial round here, because we're just getting it up and going and trying to get people interested and wanting to participate, we're having them upload all of their policies or procedures. How often are they doing competencies? What equipment do they plan on doing it on? And trying to see the commonalities there. And that's how we're ascertaining whether they're compliant with the performance measures and compliant with the regulation and compliant with the pediatric readiness standards. And in 2 years, our plan is to, during their, we call it a license, relicensure process, they will have a site visit, and we will go out and actually look at their procedures. How are you recording your education and your training? What have you done to improve this? Do you have your QI, QA programs in place? Have they impacted, your everyday operations, those types of things. So that's our plan. Our biggest barrier right now, quite honestly, is voluntary. And, people are trying to find out, well, other than, us saying it's going to be good for the kids, better for outcomes, and better treatment and better, better prepared clinicians, what is the benefit? So my biggest push has been, well, the benefit is, one, you're going to help the kids. Two, you're going to help the provider be more prepared and, calm in a situation where, they know they have the proper tools and they've been given the training and the education needed to manage the situations they're being put in. And the third one that seems to win over, sadly, bigger than anything else, is public opinion. They can go out and do a PR event. And we do the PR events with every single one of them, where newspapers come out, mayors are coming out, county officials. And that's been our biggest driver to getting an increase in our numbers. Once a couple people saw that and they started seeing it countywide and we started congratulating them, they started to jump on board. So we have probably 12 or 15 agencies right now that are in the application process of loading up their documentation and going through the different phases we have set up to verify that they meet the standards. So we'll see what happens. Hopefully it'll continue.
Awesome. Thanks for sharing.
Mhm.
Mark.
Yeah, I just had a question for Eric. One, I love the idea of pitting the services against each other and using it as we want PR too, because I found success with that, and I applaud you for doing that. The beginning part of it, and I may have misheard you, so correct me if I'm wrong, but you're using the skills standards as what's in the readiness survey each time. Is that, did I mishear you on that, or?
So we took the performance measures in the state partnership grant, and we took the standards in the pediatric readiness assessment or survey, and we incorporated them into our application process. So they're literally clicking off certain things and saying, yes, we do this, and this is how we do it. And then they either provide the educational platform or the policy or the procedure that they use to accomplish that.
So do you envision, as that assessment changes, that you're going to have to change your program?
So we do actually. The good news is our program's not in regulation. So for me, it's a matter of just going into the application and modifying maybe a question or a standard or something like that. So it's not as big of a deal. For our regulatory stuff, if things change and doesn't match up, then it becomes a challenge.
Great, thank you.
Anybody else have something to share or questions for those who have shared? All right, Casey, should we move on to the next one? All right, standardized weight estimation system, same questions. Have you been able to incorporate that into your current criteria or working on getting it in? How may you be assessing it and any enablers or barriers? And anybody just go ahead and speak up. No need to raise your hand.
Okay. Hey, it's Eric again.
There
So yeah, hi. So
Hi.
yes, we have incorporated this into our process. Everybody is required to document weights in kilograms, and if they're doing a medication, they have to use some kind of pediatric device, I guess I'll say, because you can't tag out anything else, but something like hand tebby or a lead-based weight tape type item, and that's required of them as part of the program.
Awesome.
And we haven't met any barriers with this. I mean, everybody was kind of already doing it, I think, for the most part, has been our experience.
I do think that a lot of electronic patient care reports who people use automatically convert. Like if they put in a browser color, they put in a pound, it'll convert it to kilos nicely. So it seems like that's really been a great, system.
In Maine, we do something similar that Eric mentioned is we use a statewide PCR reporting system, so everybody has to use the same one, and that converts over to kilograms automatically, and reports it in the report that way. We don't use something like what is the Broslow color, because then it's an endorsement of our state of a product, and we can't do things like that in Maine. But we also incorporate in our protocol app that's freely available, calculators that convert everything. So no matter what you put it in, it converts it all to kilograms. And lastly, we require all ambulances to have a weight-based device or system on their ambulance, and we inspect that annually to make sure they have that there.
Awesome.
And that includes link-based tapes, not necessarily scales.
Correct. It wouldn't be a scale. There's no way to keep it calibrated bouncing down the roads of Maine.
Right.
But so some have Broslow tape, some use some of the other devices, other products that are out there. Some have PD wheels. Again, we fall into that. We can't name a product or specifically recommend a product because of state statutes. But it has to meet the criteria of a weight-based device that can be used in the back of an ambulance.
Cool. Any other comments or thoughts or?
Yeah, Rachel, hi, Michael Kim from Wisconsin. Sorry, it's been a while since I joined this group.
Hey there, how are you?
Good. I have sort of logistic question regarding this specific element. I would love to see the specific language that addresses this issue. So are we measuring in kilograms and documenting in kilograms, or are we measuring and documenting in pounds and having the PCR convert to kilograms? Those are two completely different things, and we're really having a hard time reconciling those differences and what is truly safety issue or not. So I'm just wondering how each system is addressing this issue, because the traditional weight system, we're not getting over it. So how do each agency, the states, dealing with this pounds to kilogram issue?
So yeah, thanks for that, Mike. I just put the language from the actual checklist into the chat. I think that's a great point, and I will say that, you know, and I don't know if Sam Mishra is on or somebody from Michigan, but NAMSP had published a position statement on medication safety. And not all, you know, weight estimation is not purely about medications. There's equipment size based on weight as well. But the one recommendation is that, you know, some type of estimation system would be needed. And there is a lot of debate about the benefit of pounds versus kilos. And the MyMedic that was initially used by Michigan was pounds based. Other people who developed field guides use like a Brouslow or other length-based tape color. And then if you just fall into a color, then you automatically have volumetric dosing, you know, kind of created, and it doesn't matter whether you're trying to calculate based on kilos or calculate based on pounds, it's just calculated, or the volume itself is what's calculated. But I would love to hear other states on what their challenges are in that regard, and if they've made distinguishing, if they've distinguished between pounds and kilos. Certainly for the ED readiness criteria, it's about weighing in kilos, and really a force to the hospitals to shift in that direction.
Has anybody addressed that concept of kilos versus pounds within their
Mike,
program?
Mike, I know in Maine, one of the considerations we had was the risk of that 3 a.m. calculation of, you know, parents report pounds of the patient's weight. And so by allowing our system, both the protocol app and the documentation, to let you enter it in as pounds, but it automatically converts it to kilos and gives you medication doses based on the kilo weight. We took out one more step of doing that division step for pounds and figuring it out, and one more potential mistake area. So our system lets you put it in either as pounds or kilograms. There is the potential that somebody may think they're entering it as pounds, but it's really kilos, but we haven't really seen a lot of that. It's pretty obvious to say what weight what weight unit are you entering this in as, and you choose pounds or kilos and then enter your appropriate number, and regardless, it converts it to kilos and then forces you to use kilos after that.
I think a lot of agencies are following that approach, and having worked in the ED long enough, I know my nurses are putting, they do have a conversion chart also. But there are a handful of times where pounds goes into kilograms a lot and vice versa. So it is an issue that we are unable to break through for decades, as we're we're still honoring the traditional weighing and measuring system. So it's a continued challenge, and I think we just need to make sure that we do have tools provided for the providers so they minimize their errors. So it's something that I struggle with all the time, and I just wanted to see if there's any good way to resolve this issue, but we'll have to wait and see.
So Kathleen, does anybody know of an EMS agency that's using an EPCR that's flagging when a weight is potentially too high or too low? Anybody? Anyone?
I'm not quite sure whether any of the virtually available electronic patient care reports have really advanced into that degree of granularity. And I think also, you know, one of the challenges we also know is oftentimes with busy hands, busy minds, in pre-hospital care, a lot of documentation doesn't happen until after the fact. You know, it gets written down on something and then it gets plugged in later. But there, in electronic medical records, if you put in a weight that seems incorrect based on the patient's age, you'll get like a little alert that'll pop up saying, are you sure this is how much this patient weighs? That seems awfully high for their age, or that seems awfully low for their age. And so it's just another safety mechanism to, you know, mitigate errors. I'm not sure if things have moved in that direction, but I didn't know if anybody had any awareness in their industry context of anything like that at all.
All right, not seeing anything in the chat. Last chance to share how you're working through this item.
Can I share up and coming technology where
Yes, please.
yeah, there's a company that's making a COT scale. And two of our EMS agencies actually have bought into it. And there's no evidence-based research on this scale and its accuracy, but at least when we're monitoring this seems to be very accurate. But there are we're just formulating some studies to look at its reliability and its validity, etc. But there is a company that does make this. I know of only one thus far. So I think that measures in kilograms, but it needs to be zeroed and needs to have a very specific interference mitigation to make sure that they measure the correct weight. But when they go through the trouble, it's fairly accurate. So I just want to at least share there's that method that's available. But everything else is length-based and we've been trying really hard here to minimize guessing, and we've fairly successful with all the campaign, but the scale seems to be the most technologically advanced method at this point.
Great, thanks for sharing. All right, moving on to PEC. This is one near and dear to our hearts. Anybody wanna pipe in about their experience with this one? I know there's some programs out there who didn't include it initially and may be working on or have added it. So I'd love to hear from you guys on how that may have worked if it wasn't included in your initial criteria, but you've been able to add it in future revisions, or any other responses to the questions on this slide.
Hey, it's Eric. So we have, of course, included this because it's one of the standards. And what we do is everybody kept coming back to us and saying, well, what is a PEC? What do we do with a PEC? So I literally send them to the EIIC website. And I'm like, here you go. Here's the link. Just go there. And now we've included that in our documentation that we send out to all the agencies of interest. So it's been very helpful.
Great. Glad to hear that those resources are being used and are helpful.
Mark, are you using things like those PEC role descriptions on the EIC website and things like that, or?
So we refer back to the EIIC website as frequently as possible. So if it's already built out and we don't have to rewrite it, redefine it, or build it out on ours, we include a link. The only problem with doing that, though, I would warn you, is that links can change. So if you're putting it on anything permanent, that could be a problem.
Well, and then the flip side is if you include the document and the document updates and you don't know it, then you're referencing an old one. So it's kind of a challenging process either way.
That could be a problem too.
Sorry, I didn't mean to call you Mark. I was not hearing
I knew
well enough.
what you meant. Mark's a good looking guy too.
Both of you.
Can I throw out a question?
We're twins. It's okay.
Can I throw out a question regarding the overlap of responsibility? So let's say if you are assigning a PEC, does that person just do pediatric work? Or can that person also be doing other work such as quality improvement, etc.? So we have a lot of agencies that are limited resources, so double, triple, quadruple responsibility does tag on. But as being through the administrative leadership course as a pediatrician, I know having being a medical director for an agency and being a pediatric PEC, it just does not wash. So I'm just wondering, how does anybody trying to tease out that specific pediatric emergency care coordinator role while doing other responsibilities, and how do you guys tease that out?
That's a great question, Mike. Does anyone have any experience with kind of how they've handled it in their agencies or their states?
So in New Jersey, we allow our participating agencies to share roles. And what we do is we try, if they're going to be sharing roles, that they don't share it with too many, because we don't want to water it down. So, and if we see that they're not doing something, we may ask for, additional time, like what is their time commitment? Is it 50%, 50%? And what projects are they actually doing? So I think our 2-year mark, at looking back at the last 2 years, for our renewal agencies, will be a real eye opener, because we're going to assess exactly what they were doing over those 2 years and what their accomplishments were. And we'll have a better answer for you probably about 18 months.
We'll be counting on you, Eric.
Great.
See, we got in the chat, Marco says Indiana requires each agency to identify a PEC on the renewal of the agency, or if there's a new EMS agency. We also have a pre-hospital PEC roles and responsibilities document. Oh, from the one that came out of the TI grant from Louisiana. And Margo, I think what you're saying is the EMS Bureau has that written into their requirements for relicensure, correct?
It's not currently in state code because we're redoing the statute right now, but for the forms that live on the website, because EMS sits with Department of Homeland Security, it is a requirement for their renewal. Every 2 years is when they do the renewal. And then if you become a new EMS agency, and we found that this really helped with our PPRP results, getting agencies to complete the assessment, because we have the identified person. And so we don't have criteria yet for a pre-hospital recognition program in the state. But we are going to be embarking on that further.
Great.
Thank you.
You're one step further than lots of states with programs.
Oh, I forgot what I was going to say, Rachel. We have 10 health preparedness districts in the state of Indiana. And last year we visited every single one, and it was an opportunity for me to talk about the PEC role with everyone that was in attendance. We also have monthly in-service with the state EMS medical director, and periodically I do presentations to them as well.
And you're educating the medical directors on the PEC role as well?
Yes, medical directors. Indiana has several medical directors, of course, and for over 800 EMS agencies. And then just trying to make sure that we identify who that PEC is, but then make sure that we communicate with that person and get to know that person, and try and network and build our network of pre-hospital PECs alongside our ED PECs.
Awesome.
Thank you.
Thank you. Go ahead, Wayne.
Yeah, that's one of the things we're trying to do, is blend the pre-hospital and ED PECs together, where they work together, but also across the state for shared information, shared resources. It's my next step. I've had learning sessions for our pre-hospital PECs, tried to hold them quarterly, but work effort doesn't always allow that. The one thing about the PECs, that for the pre-hospital PECs, and backwards, I think I was probably one of the ones that was pursuing the shared PEC idea, and we've added the think outside the box of a PEC doesn't have to be a member of the organization, an employee or a volunteer, but it could be a community member. It could be somebody with pediatric expertise, somebody who's more comfortable in that realm, that their support has more benefit to the effort. And so we added that community type of individual to the term community PEC, which was our shared PEC between the EMS community. And that was typically our non-transporting services utilizing a transporting services resource, because the non-transporting, typically fire department QRSs, don't have the depth of people and resources. So tagging on to their local transporting agency was not only a norm, but a great benefit and resource. So we expanded that term community to include community members within the physical community that could support the EMS agency.
So it's an interesting concept, Dwayne, because the definition that we've put forth on a PEC really includes the concept that they have a solid knowledge of the workings within the EMS agency and thinking about procedures and protocols and education and such. So how do you address a community member who doesn't know anything about the EMS agency addressing things that are so very agency specific?
I see it no different than trying to address the EMS agency representative who doesn't have a great background on pediatrics and its education and engagement with people who do. So we're engaging EMS PECs with EDs who may have a little better knowledge and resource. We're engaging the community PECs with the EMS agency so that they have an understanding of the need and they can provide the resource of, the hows and whys with their expertise and background, and it blend together. It's not a standalone, separate. It's a working effort, and they're not there to become EMS experts, as I don't believe our PECs are going to be pediatric experts, but they should have some knowledge and some experience, and to expect, and I'll use my own state, 1,200 EMS agencies to have a pediatric expert in their agency is inconceivable. So I'm looking on ways to share those resources or to adapt those resources with other expertise that can help them do their job and facilitate the program and the program expectations at the agency level.
Okay. I just want to clarify that I don't think we've ever indicated this person needs to be a quote pediatric expert. It's just the individual that is there to ensure pediatrics are considered in all things necessary. Like I mentioned, procedures and protocols, and that there's an education. So it would never be a quote expert. It would just be somebody who is kind of taking the torch to ensure pediatrics are incorporated into all the things that need to be.
Oh, I agree. That's kind of the feedback I've gotten of, we don't have expertise in pediatrics. That's okay. We're going to get you the resources, and some of that experience comes from interfacing with experts in your community, whether it be, the pediatrician, the hospital ED, or the local or regional pediatric receiving facility, whatever it might be, to get you those resources, whether that be through education or hands-on skill management or whatever. So yeah, I agree. It's not the program's standard, but it's almost somewhat of a self-imposed standard by what people think a pediatric emergency care coordinator needs to be, and really what it doesn't need to be. It just needs to have that desire, that commitment, and to be quite honest with you, the mindset of we can do this better, but how can we go about doing that?
And I think that that's a really great point. And in the PPRP assessment, everyone all agencies were asked, do you have a PEC? And if so, what do they do? Who are they? Are they a medical director? Are they a staff line person? Are they this or are they that? In addition to the questions. And Eric, you have your hand up, but I just put something in the chat for the group. We in Colorado are hosting a PEC seminar right now in Telluride. Nicolina is down there, and that's why she's not on this call today. And this is a room of 60 PECs both hospital and emergency and EMS all coming together in the southwest part of the state to learn about pediatric readiness. And again, the benefit that we've done here is that they all get to know each other. So there's that connection between EMS agencies and hospitals to kind of know how to do that collaboration. But anyway, Eric, you have your hand up.
Yeah, just a quick question for the group. We have a lot of advanced life support agencies here to provide medical command for our basic life support agencies. And the question has been asked, and we haven't kind of said it was okay yet. Does anybody see any reason why we couldn't allow a ALS agency provide a PEC for, say, 5 other BLS agencies?
Oh, absolutely. In fact, that's part of the idea of sharing a PEC or having like a regional PEC that supports other agencies if time allows, right? I think that's kind of to all the questions above, right? Like, how do you get a PEC when you don't have enough people to do
Right.
the work of the agency? But yeah, I think there have been some states that have done that. I think is Stacy on Idaho has regional PEC leads, and I believe Utah kind of does a similar format as well. And then there might be more PECs under them, but they're kind of like taking the role as this regional PEC that can then support other PECs when needed, or also serve as the agency PEC if that agency can't find one.
Yeah, when they were pitching it, they're saying that they would have a person just doing PEC. And I'm like, well, that sounds great. And then they would oversee all the BLS agencies that come under their medical command. So
yeah. Michael, nice to see you.
Good afternoon, everybody. I'm Michael Berg, and I am shadowing Dave Edwards, who's going to be retiring as of July 1st, and pretty much taking over the MSc program for the Commonwealth of Virginia. I just wanted to echo what a couple of comments that I heard that were mentioned. Although we may not have as many licensed EMS agencies in Virginia as some of my colleagues here, one of the challenges are those agencies that have hundreds of employees and or members, and those who have 10 or 15. The disparity is the availability of personnel to handle all the different responsibilities that come along with managing and running an organization. So the concept that you identified of having somebody who can share that responsibility among different organizations is the same concept that we encourage when we ask them or require that they have a designated infection control officer. It doesn't have to be somebody that is specific to that organization, but they do have to have the knowledge base and the understanding of the organization's resources and who to contact. So I applaud that. And I think that's a great way to spread the wealth and also to get more people to collaborate together. So thanks for the opportunity to speak.
Mark?
I was just going to kind of echo what Michael and nice to meet you, Michael, and Eric said. In Maine, we have about 275 agencies, which is more than some states, but a lot less than many others. One of the challenges we have is about 50% of our services do less than 1 call a day. And about 30% of our services do less than 1 call a week. But we are gently prodding them to try to regionalize resources. There's a lot of fight with that. Everybody wants their own service. But we have a lot of medical directors that cover multiple agencies. And so when we emulate that by using our goal is to use a PEC that does something similar, whether it's a medical director that has an understanding of EMS. And I would caution folks that not every medical director understands EMS at all. But whether it's an ALS provider or someone else, to use that so that there's consistency in that area is one of our goals, to try to save staff time. And we have organizations that may have 3 members and they're already doing so much. To have somebody being able to help their neighbors is mutual aid of administrative support, so to speak. So that's how we're approaching it.
Thank you. And I just noticed the time. So I want to be considerate. I think I I can at least stay on if people want to keep chatting about this, but please feel free to drop if you have other meetings. Like I had yesterday, which was like 5 hours in a row, which we love. So
I'm able to stay on as well briefly, but I have a question about this concept of a regional PEC, and if they're doing QI, do you have any issues of their ability to look at charts of an agency they don't directly work for, like a pediatric care case? And has that come up as an issue or a barrier?
that's a great question, Kathleen, and I'm not sure anybody who is currently doing that is on the call. But we should maybe make note of that for future exchange discussions, because I think that would be really something interesting to kind of flesh out.
Well, Dr.
Rich, I would-
Allegese, in Maine, we allow that up to the agency, so agencies can give permission, and they literally could give permission to you to come in and do a QI, even though you're out of state. It's their responsibility for the HIPAA and PHI requirements, and they fall under their statutes or their rules and guidelines. But we have lots of regional managers that are added to rosters and given privilege to look at those particular agencies to do QI. So that does exist and is allowable, at least in our state. And I know we use Image Trend, so Image Trend does allow for that if you're on the roster for that agency.
That's really helpful, Mark. Cynthia, you've had your hand up super patiently. Do you want to speak up?
Cindy, you're still muted if you're talking.
Sorry, I think I double clicked that.
There you go.
There we go. Specific to QI, we have a different challenge. Without looking at the numbers, I would say 10% of our what we call pediatric champions, which are PECs, are also the QI officer. We have probably another 20% who can get into that information. And I would say 50% at the moment, 50% of our pediatric champions are struggling to, not on a case by case basis, but at getting access to agency wide, which for us is a county, report writing. And so we are starting to write standardized reports at the state level for pediatrics based that then the champions would hopefully get access to. But there's in our career and combined systems, QI officers are very possessive of that role and responsibility and that data. So we have approached the medical directors by having both Caleb Ward and Jen Anders present to them where we stand as a state. Now, that was 2 weeks ago. Now they all want to know where their county stands. And we're not giving them that information because they can go get it. But getting QI officers and PECs together is a long-term goal, I guess, would be the PC way of saying it.
Yeah, thank you, Cindy. Jacqueline.
Good afternoon, guys.
Hello.
Can you all hear me?
Yes.
Okay, so in the Virgin Islands, we have a unique, and I guess a smaller area because we have 3 islands and that we do have a PEC on each island. But the great thing that we have is our documentation charting, because with our documentation charting, instead of us having to build a portal for our EMS to upload their charts, we have it set up where they're on the operational side and our office of EMS is on the the command side. And then we did a contract with the hospital. So with the hospital, like for instance, our nurse coordinator in the ER is a PEC. Our nurse manager is a PEC. Our pediatric nurse coordinator for NICU and PEDS is a PEC. And so because they all work in the ER and they have with the signed contract in terms of getting access to the EMS data when the ambulance take them in, they can also be able to see the type of calls that came into them because they might need it for risk management or to be able to view the chart for a patient that comes in. And then we built in a special report. So every month automatically, once we hit on a special pediatric report, it brings up all of the pediatric calls that those agencies had in each of the 3 different districts. And then the medical director happens to be the medical director for the whole district, even though we're separated by water. And so one of the things that he did an excellent job was within our QA/QI policies, because he wrote the type of pediatric calls, that all of those calls must be critiqued. And then our pre-hospital PECs, one of them is also a nurse besides being a paramedic, and she's the supervisor. And so when they do their skill check, they invite us from the EMSC program so that we can come sometimes and audit the skill check. And one of the things that they do is cars that they haven't been on in a long time, or if they didn't have none of those cars, they just throw in a MAC call for that crew and have them perform the skills besides the other things that that we do. So that's a little bit about how we do it a little different.
That's great. It sounds like really great kind of collaborative work between the EMSC program, EDs, and EMS agencies, all those spokes working together. That's awesome. Thanks for sharing.
This is Cindy, and I have a second question if there's time. Otherwise, we can do it another time. We, to my knowledge, don't have anyone who is a full-time pediatric EMS care coordinator. They're all either supervisors or training officers or assigned to the academy. All of those also have to work shifts to keep their clinical skills up, but 80% are practicing EMTs or paramedics, and they fit this in. And as I put in the chat, I was just told by one jurisdiction, no more work until after July. I don't have any more overtime. So,
Yeah, it's not a question we've asked in past assessments. Like, I don't think we ask. We just ask, do you have one? Not how dedicated are you to that role? So I don't know that we would have a very good idea unless individual states have somehow been able to get that question out.
and I think that our whole program would crash if I said they had to have 10 hours a week protected time.
Oh yeah, that's why, I mean, I think that's why all of our definitions are very kind of squirrely on not saying that, just with the realization that it's just not possible.
Yeah.
But it would be interesting to know how many maybe were either 100% dedicated or split 5 ways.
And an estimate of hours per month
Mhm.
might be a gentle way of asking. I am not the research person. I am the administrative, now budgeting person. But I know some of our people are doing a lot, but we only get about an 85% attendance at our 4 meetings a year. They're required to be at 3 of 4, and by required, I mean we track it. Nothing happens if you don't. And part of that is because we're all adults and have fragile parents and fragile children and overtime and funerals to attend for line of duty deaths. I mean, the list of why people haven't come are all legitimate. The only one I can't quite swallow is not until after July 1, I have no more overtime budget. And this is a county that's had a champion for 6 years.
Oh, wow.
And our state is 3 billion in the red. So, it may just be unique to Maryland, and I'll be quiet and listen to others.
Anybody else have a feel for time commitment of their PECs?
Does anybody actually, what proportion of the agencies have a PAC that actually has a protection time for? From my understanding, this is a labor of love and a passion for kids. And if there are, I mean, it'd be great. It's a great model to have, but obviously funds and time are limited. So
Yeah, getting comments that few, if any, and none have protected time. So it
Yeah.
is definitely a labor of love.
yeah, absolutely. I think that's the thing. And I have some couple of a question and a comment. The question is, has there been any evidence or study looking at the productivity of the PEC role as it's defined currently, to see what are some of the characteristics, so what are some of the qualifications that we should be looking for an effective PEC in pre-hospital settings? So that's my first question, and I'm gonna move on to the second one because I'm gonna forget this. The second is, as we're talking, I've just been through the EIIC website to look at the PEC descriptions, and there are 11 references in their toolkit here. PEC roles and job descriptions. There are one or two similarities in each of the documents, but they're all different. And I think from my perspective, that makes things a lot less specific in detail for people to understand exactly what the job role is. So I'm just wondering whether should there be a common denominator specific, a must role for a PEC, and then leave everything else sort of as an option? Because as I look at all these 11 right now, and they're all different. And if I were to look at all these, I'd be very confused. That would be my comment.
So Mike,
Oh, go ahead,
can I
Kelly.
just answer a couple of your questions real quick?
Sure.
Two things. One, the PEC Learning Collaborative had a report generated back to HRSA, and then also a paper published that we can send to this group that did some kind of pre and post interviews with PECs on what is it that they do and how do they spend their time. Two, the prior studies of the impact of PECs have been really that correlation between the presence of a PEC and the skills check metric, because that's what we've been collecting data on. My final point would be that the PPRP data our PPRP assessment did not ask if you have a PEC, are they paid? Or do they have a dedicated FTE? So we cannot collect that information from the PPRP assessment. That might be a question to get added to in future assessments to do a better drill down on that. But what is known, or what I think we will see, is that the role of a PEC has significant downstream effects on all the other things the agency's doing to be PEDS ready. More likely to have family-centered care, more likely to do QI, more likely to do interactions with systems of care and things like that. So then again, our next step is like the effectiveness is really the patient outcome piece. Now the NEMSIS dashboards and things like that may be a way to kind of explore pediatric readiness scores and EMS agency activities and patient outcomes, but I think we're still a little far from a good data set to kind of explore that. But that's just some ways to kind of be able to answer that question. With regards to all the different roles, I think every EMSC program that put a role description on that website, it was homegrown, and it was really out of the learning collaborative that was now conducted 7 years ago. So I think this new PEDS ready information from the assessment may help really redefine that role of a PEC. But that was long, again, just to kind of get to the heart of some of your questions as we know it right now.
Yeah, I really appreciate that. I mean, this is a very difficult concept, a difficult issue to resolve, but I think having a PEC, regardless of how many different hats, it's going to help the matters, and it's going to really help focus and have a voice for the kids. Speaking of the assessment, any news on when the assessment will be released?
HRSA has been reviewing ALS data. It has had to go to the highest level. And so when you have to kind of move things up a very high chain, it takes time. So that has been a real barrier. For full disclosure, the data on the overall national readiness is being presented at PAS in Hawaii in a couple of days. And there is a draft manuscript, and we will be, we've kind of pushed on HRSA to be able to submit the draft manuscript soon, but they have asked that it not be published until the state data has been, you know, kind of released to the states, and they've not given any time frame for that. So
Okay, thank you.
it is a very frustrating place for us to be. We feel very stuck in the middle.
Yep.
I do need to pop off to get to another meeting as well, but I really appreciate everyone's robust conversation here today. And if others can stay on and continue to talk, that sounds wonderful.
Thank you, everybody, for a great conversation, great questions. Really appreciate your involvement and the great work you're doing.
And if you're still with us, we look forward to seeing you again next month and hearing updates from you all. So here are the states and territories that have been invited to share next month. So we look forward to hearing from you then.
Thanks, everyone.
Bye, everyone. Thank you.